My name is Jon Shaffer. I'm a medical gastroenterologist working in the intestinal failure unit at Salford Royal Hospital in the United Kingdom. I'm going to talk to you about intestinal failure, and in particular acute intestinal failure. We have subdivided this topic into types 1, 2 and 3. Type 3 is chronic intestinal failure, and I'll not discuss this any further. Type 1 and 2 are the acute forms that I will discuss. In type 1, these are generally patients on surgical wards or intensive care units whose guts have ceased to function because of some generalized insult to the patient. The gut themselves are intrinsically normal. These patients, given the treatment of the underlying condition, will resolve spontaneously, and they will require just supportive nutritional therapy during this period. Type 2 failure is more complex. These patients have diseased bowel, often post-operatively, associated with fistulae, with proximal stomas, with high outputs, with metabolic upsets, and intra-abdominal sepsis. They are best managed, if possible, in a specialist unit by a dedicated team. The priorities in these patients are firstly to assess and reassess for sepsis, as this is the major killer in these patients. Once that has been sorted out, one can attend to fluid balance, electrolyte balance, and nutritional therapy as appropriate. Many of these patients will require parenteral therapy. In addition, these patients often have issues as far as wound care, stoma care, and psychological care, all of which require very expert nursing involvement in these particular group of individuals. Once this has been performed, the patient will require some detailed radiological assessment to find out where the sepsis occurs, where the fistulas arise from, etc. All patients will get a CT scan on admission, but then will require fistulography and detailed contrast radiology. Only when the patient has achieved the stability, one has a detailed anatomy of what is happening, only then can a surgical plan be brought into play to consider when would be the optimal time to manage these patients long term. An important key in this last issue is the fact that a serum albumin should be at least 30 before any kind of reanastomosis should be performed. Thank you.